Question 1. A 62-year-old male with a history of COPD is in respiratory distress. His respiratory rate is 28 breaths/min, and his SpO2 is 88% on room air. The most appropriate initial oxygen delivery device for this patient is A. Nasal cannula at 2 liters per minute.
B.
Non-rebreather mask at 15 liters per minute.
C.
Simple face mask at 6 liters per minute.
D.
Bag valve mask, BVM, with reservoir. Answer: B. Non-rebreather mask at 15 liters per minute. The core concept here is recognizing respiratory distress and treating hypoxia, regardless of the patient's underlying chronic obstructive pulmonary disease. The key clues are the signs of distress, rate of 28, and significant hypoxemia, SpO2 88%, indicating the patient needs high-concentration oxygen immediately. Current guidelines recommend providing high-flow oxygen, typically via a non-rebreather mask at 10 to 15 liters per minute, to achieve an SpO2 of 94% or greater, even in COPD patients. Withholding high-flow oxygen due to concern over hypoxic drive is generally discouraged in acute distress, as the immediate threat is severe hypoxemia. An easy way to remember this is that a hypoxic patient, even a COPD patient, is a dead patient, so fix the immediate oxygen problem first. Question 2. The primary anatomical structure responsible for the exchange of oxygen and carbon dioxide in the lungs is the
A.
bronchi,
B.
trachea,
C.
bronchioles, D. alveoli. Answer: D. alveoli. This question tests basic respiratory anatomy and physiology, specifically the site of gas exchange. The key concept is that the alveolar sacs are the terminal, ND air spaces in the lungs, surrounded by capillaries. Oxygen diffuses across the thin membranes of the alveoli into the blood, while carbon dioxide moves from the blood into the alveoli to be exhaled. The other options are conducting airways that simply move air in and out of the lungs. For example, a patient with pneumonia has fluid in the alveoli, which dramatically slows the gas exchange process. Remember that the tiny alveoli are where the air and the blood actually meet to trade gases. Question 3. A 28-year-old construction worker has fallen approximately 20 feet from scaffolding. He is conscious and complaining of severe pain in his legs. You must immediately consider
A.
the need for an immediate glucose check.
B.
A non-life-threatening extremity injury.
C.
The potential for multi-system trauma and spinal injury.
D.
Applying a pressure dressing to the leg wounds. Answer: C. The potential for multi-system trauma and spinal injury. This question assesses the critical skill of recognizing a significant mechanism of injury, MOI, in trauma assessment. The key clue is the fall approximately 20 feet, which is a high-energy MOI mandating a high index of suspicion for severe injuries, especially to the spine and pelvis, even if the patient is conscious. Therefore, spinal motion restriction and a rapid trauma assessment are prioritized over immediate, focused treatment of the leg or a glucose check. For instance, an 8-foot fall in an adult is often the threshold for considering a severe MOI that could cause unseen internal damage. Always consider the hidden injuries, particularly spinal, with any significant fall. Question 4. A patient is found unresponsive, apneic, and pulseless. The cardiac rhythm displayed on the monitor is ventricular fibrillation, VF. The most appropriate first intervention, assuming an AED is immediately available, is
A.
begin chest compressions.
B.
Administer 1 milligram of epinephrine 4/IO.
C.
Defibrillate immediately.
D.
Establish an advanced airway. Answer: C. Defibrillate immediately. This core concept is the priority management of ventricular fibrillation, VF, in cardiac arrest. The key clue is the rhythm, ventricular fibrillation, VF, which is a shockable rhythm where the heart muscle is quivering uselessly. Defibrillation is the only intervention that can immediately reset this rhythm, making it the highest priority per the adult cardiac arrest algorithm. For example, The sooner a defibrillation shock is delivered for VF, the higher the chance of survival. Always remember that for an arrest patient in VF or pulseless ventricular tachycardia, shock first, then compressions. Question 5. You are assisting a patient with their prescribed nitroglycerin antigen. A key contraindication you must rule out before administering the medication is
A.
history of chronic headache,
B.
systolic blood pressure below 120 millimeters of mercury,
C.
use of an erectile dysfunction, medication within the last 48 to 72 hours,
D.
current heart rate below 60 beats per minute. Answer: C. Use of an erectile dysfunction, medication within the last 48 to 72 hours. This question tests EMT pharmacology knowledge, specifically contraindications for common cardiac medications. The key information is the drug nitroglycerin NTG, which is a powerful vasodilator, meaning it opens up blood vessels and lowers blood pressure. Combining NTG with ED medications like sildenafil, Viagra, or tadalafil, Cialis, which are also potent vasodilators, can cause a life-threatening, refractory drop in blood pressure. The drug's indication for chest pain does not outweigh the contraindication from a recent ED drug use. Remember that a patient's systolic blood pressure must generally be above 100 millimeters of mercury for safe NTG administration, but the use of ED drugs is an absolute contraindication due to the risk of severe hypotension. Question 6. What is the primary method of preventing the spread of infectious disease during patient care, according to standard precautions?
A.
Wearing an N95 respirator mask.
B.
Properly disinfecting the ambulance after the call.
C.
Strict hand washing and use of personal protective equipment, PP.
D.
Limiting patient contact time to under 15 minutes. Answer: C. Strict hand washing and use of personal protective equipment, PP. This foundational question assesses understanding of EMS operations and infection control. The key concept is standard precautions, which applies to all patients and all bodily fluids, and the most effective component is good hand hygiene. Using gloves, gowns, eye protection, and a mask, PPE as appropriate, combined with diligent hand washing before and after every patient encounter, is the single most important action to interrupt the chain of infection. A practical example is putting on gloves before touching the patient, and then washing your hands immediately after removing them, even if the gloves did not visibly tear. Make it a habit. If you touch the patient, the equipment, or the truck, wash your hands. Question 7. You arrive on scene to find an adult patient who is unresponsive and breathing at a rate of 4 shallow breaths per minute. Your immediate priority for airway and ventilation management is to
A.
Insert an oropharyngeal airway, OPE.
B.
Apply a non-rebreather mask at 15 liters per minute.
C.
Perform a jaw thrust maneuver and begin positive pressure ventilation with a bag valve mask. B.
D.
Place the patient in the recovery position. Answer: C. Perform a jaw thrust maneuver and begin positive pressure ventilation with a bag valve mask. B. This critical question tests the ability to recognize and manage inadequate breathing. The key clues are unresponsive and a rate of 4 shallow breaths per minute, which indicates severe respiratory failure and the patient being apneic or near apneic. Positive pressure ventilation with a BVM is immediately required to force air into the lungs and supplement oxygenation because the patient cannot sustain life with such shallow, slow breaths. The jaw thrust maneuver is used to open the airway while protecting the cervical spine in an unresponsive patient of unknown trauma. An OPA is inserted after the airway is opened and while ventilation begins, but it is not the primary intervention for the severe respiratory depression itself. Always remember to ventilate patients with inadequate breathing immediately before moving to adjuncts or other actions. Question 8. A 45-year-old male is experiencing classic signs of an allergic reaction after a bee sting, including widespread hives, wheezing, and facial swelling. If his local protocol allows, the EMT may administer or assist the patient with
A.
oral glucose,
B.
aspirin acetylsalicylic acid,
C.
Activated charcoal.
D.
Epinephrine, adrenaline via autoinjector. Answer: D. Epinephrine, adrenaline via autoinjector. This scenario assesses the EMT's ability to identify and manage anaphylaxis, which is a life-threatening allergic reaction. The key clues are the rapid onset of hives, wheezing, bronchospasm, and facial swelling, airway compromise, indicating a systemic, severe reaction. Epinephrine is the medication of choice because its alpha effects cause vasoconstriction to raise blood pressure and its beta effects cause bronchodilation to open the airways. A practical example is an adult patient receiving 0.3 mg of a 1.000 solution intramuscularly in the lateral thigh using an autoinjector. Epinephrine is the only medication that directly reverses the life-threatening effects of anaphylaxis. Question 9. You are treating a patient with a suspected tension pneumothorax. As a paramedic, the most critical definitive treatment you can perform is
A.
Applying an occlusive dressing to the chest wall.
B.
Initiating immediate needle decompression thoracostomy.
C.
Placing the patient in a Fowler's position.
D.
Administering a fluid bolus. Answer: B. Initiating immediate needle decompression thoracostomy. This is a paramedic level question focusing on the definitive management of a life-threatening chest injury. The concept is that a tension pneumothorax occurs when air builds up in the chest cavity, compressing the heart and major blood vessels and causing circulatory collapse. Immediate needle decompression, or a needle thoracostomy, relieves the pressure and is the only definitive intervention that paramedics can perform in the field. For example, the patient will present with absent lung sounds on one side, difficulty breathing, and signs of shock, which all rapidly improve upon needle insertion. Recognizing that this condition is a mechanical problem requiring a mechanical solution is the key to mastering this concept. Question 10. You are performing CPR on an adult patient with an advanced airway in place. The correct compression to ventilation ratio for this patient is
A.
30 compressions to 2 breaths.
B.
Continuous compressions with 1 breath every 6 seconds.
C.
15 compressions to 2 breaths.
D.
Continuous compressions with 1 breath every 10 seconds. Answer: B. Continuous compressions with 1 breath every 6 seconds. This question tests knowledge of the 2020 to 2025 cardiac arrest guidelines, specifically for patients with a definitive airway. The key information is advanced airway in place, which changes the ventilation strategy from synchronized to asynchronous. With an advanced airway, ventilations become asynchronous, separate from chest compressions, allowing for continuous, uninterrupted compressions at a rate of 100 to 120 per minute. This means providing 1 breath every 6 seconds, which equates to 10 breaths per minute, while compressions continue. For example, the ventilator delivers a breath while the compressions are ongoing, maximizing perfusion. Here is an easy way to remember it. Once the tube is in, stop pausing for breaths. Question 11. What is the most common cause of cardiogenic shock?
A.
Severe allergic reaction.
B.
Spinal cord injury.
C.
Severe left ventricular failure due to myocardial infarction. MI.
D.
Significant blood loss. Answer: C. Severe left ventricular failure due to myocardial infarction. MI. This question tests understanding of the underlying causes and classifications of shock. Cardiogenic shock is defined as the heart's inability to maintain cardiac output sufficient to meet the body's metabolic demands, primarily due to pump failure. The key word is cardiogenic, meaning the problem originates in the heart, and the most common reason for this is the death or damage of a large portion of the heart muscle from a myocardial infarction, heart attack. For example, if the left ventricle cannot effectively squeeze blood out, fluid backs up into the lungs, pulmonary edema, and the rest of the body becomes hypoperfused. Remember, cardiogenic shock is a plumbing problem, but the pump is broken. Question 12. You are called to a pediatric patient, a 5-year-old who is actively seizing. The patient has a known history of a seizure disorder. After ensuring scene safety and airway patency, the paramedic priority intervention is
A.
administering an anticonvulsant medication, e.g., midazolam or diazepam.
B.
Performing a full head-to-toe trauma assessment.
C.
Applying a cervical collar.
D.
Inserting an oral glucose preparation. Answer: A. Administering an anticonvulsant medication, e.g., midazolam or diazepam. This paramedic-level scenario tests the management of an acute pediatric medical emergency, specifically status epilepticus, or a prolonged seizure. The key clue is actively seizing in a pediatric patient, which requires immediate chemical termination if the seizure has lasted longer than a few minutes or is continuous. Anticonvulsant medications like benzodiazepines are the standard of care to stop the seizure and prevent potential long-term damage. The full assessment and cervical collar are secondary to the immediate life threat of an extended seizure. A practical example is giving 0.2 mg/kg of midazolam Versti intranasally to quickly stop the seizure activity. Remember, prolonged seizures cause brain injury, so the priority is to stop the brain from seizing. Question 13. A 72-year-old female presents with slurred speech, a left-sided facial droop, and weakness in her left arm that started 30 minutes ago. Your primary concern should be to
A.
transport her to the closest hospital immediately.
B.
Determine the exact time of symptom onset, last known well.
C.
Check her blood pressure in both arms.
D.
Administer supplemental oxygen via nasal cannula. Answer: B. Determine the exact time of symptom onset, last known well. This question tests the management of a suspected stroke patient. The key clues are the classic symptoms: slurred speech, facial droop, unilateral weakness, and the critical information needed for the receiving hospital. Determining the exact last known well time is crucial because it dictates the patient's eligibility for time-sensitive, definitive treatments like thrombolytic, clot-busting therapy, which has a narrow administration window. While rapid transport is important, knowing the time of onset is the most critical piece of data you can provide. For example, if she was last known well 3 hours ago, she may still be eligible for treatment at the stroke center. Always consider the stroke patient's treatment window. Time is brain. Question 14. When should the secondary assessment be performed on a stable medical patient?
A.
Before the primary assessment and initiation of treatment.
B.
En route to the hospital.
C.
Immediately after the primary assessment, management of life threats, and obtaining vital signs.
D.
After a complete physical exam is finished. Answer:
C.
Immediately after the primary assessment, management of life threats, and obtaining vital signs. This foundational EMS operations question tests the proper sequence of patient assessment. The key concept is that the primary assessment, A, B, C, D, E, focuses on identifying and managing immediate life threats, which must be completed first. Once the primary assessment is complete and all immediate life threats have been treated, the secondary assessment, which includes a focused physical exam and gathering the sample history, follows before initiating transport. For a stable patient, this is done calmly on scene before departure. Remember the assessment flow. Primary assessment. Treat life threats. Secondary assessment. Reassessment. Question 15. A patient has an open chest wound with air bubbling from the site upon exhalation. The most appropriate immediate treatment is to
A.
cover the wound with a dry, sterile dressing and apply direct pressure.
B.
Administer oxygen and place the patient in the recovery position.
C.
Cover the wound with a 3-sided occlusive dressing.
D.
Insert a needle decompression at the 5th intercostal space. Answer: C. Cover the wound with a 3-sided occlusive dressing. This question tests the management of a penetrating chest injury, specifically a sucking chest wound, open pneumothorax. The key clues are open chest wound and air bubbling, indicating air is entering the chest cavity from the outside. The standard of care is to immediately seal the wound with a non-porous, occlusive dressing, taping 3 sides, which stops air from entering while allowing any built-up air to escape during exhalation. This dressing converts an open pneumothorax into a simple pneumothorax. A practical example is using the plastic wrapper from an N4 bag as the occlusive material. Always remember to seal the hole with a 3-sided dressing to prevent a life-threatening tension pneumothorax. Question 16. What is the standard adult dose and route for administering aspirin, acetylsalicylic acid, in the pre-hospital setting for a patient with suspected acute coronary syndrome, ACS?
A.
81 milligrams, orally chewed.
B.
324 milligrams, 4 tablets of 81 milligrams, rectally.
C.
324 milligrams, 4 tablets of 81 milligrams, orally chewed.
D.
162 milligrams, intravenously. Answer. C. 324 milligrams, 4 tablets of 81 milligrams, orally chewed. This pharmacology question addresses the proper administration of a common EMT-administered medication for cardiac emergencies. The key concept is the antiplatelet effect of aspirin, which prevents new clots from forming or existing ones from worsening, and the correct dose for this effect is 324 milligrams. The medication must be administered orally and chewed so that it is absorbed quickly through the buccal mucosa and stomach lining to reach the bloodstream faster than if it were swallowed whole. Chewing the 4 baby aspirin tablets maximizes its onset of action, giving the patient the best chance for clot prevention. Always remember aspirin is given chewed for rapid onset in a suspected heart attack. Question 17. A 68-year-old male is unconscious and has a blood glucose level of 45 milligrams per deciliter. He has a patent airway, but is not protecting it adequately. After establishing N4, the paramedic should immediately administer
A.
oral glucose gel,
B.
glucagon intramuscularly,
C.
50% dextrose D50 intravenously,
D.
a normal saline bolus. Answer. C. 50% dextrose D50 intravenously. This paramedic-level medical emergency question tests the management of severe hypoglycemia in an unconscious patient. The key clues are unconscious, blood glucose level of 45 milligrams per deciliter, severe hypoglycemia, and for established. The fastest, most effective way to raise the blood sugar in an adult with N4 is to administer D50, as it works almost instantaneously to reverse the neurologic deficit. Oral glucose is contraindicated in an unprotected airway, and glucagon is a slower alternative used when N4 access is not possible. For example, a typical dose is 25 grams of D50 administered via a large bore 4. Always choose the fastest acting and most definitive route for critical interventions. Question 18. An adult trauma patient presents with jugular vein distension (JVD), muffled heart sounds, and hypotension despite aggressive fluid resuscitation. This classic triad of symptoms Beck's triad is indicative of
A.
massive hemothorax,
B.
neurogenic shock,
C.
pericardial tamponade,
D.
flail chest. Answer. C. Pericardial tamponade. This question assesses the recognition of a life-threatening traumatic condition using a classic presentation. The key clue is the combination of signs, known as Beck's triad. Jugular vein distension (JVD), muffled heart tones, and hypotension (low blood pressure), which indicates obstructive shock. This triad is caused by blood collecting in the pericardial sac around the heart, which prevents the ventricles from filling effectively. This condition is a mechanical problem that significantly impedes cardiac output. For example, the fluid accumulation outside the heart muscle prevents the heart from stretching to receive more blood. Always associate Beck's triad with a pericardial tamponade. Question 19. A 3-year-old patient has a fever, is drooling, and is sitting upright, leaning forward with his chin out, tripod position, resisting any attempt to lie down. This presentation is most suggestive of
A.
foreign body airway obstruction,
B.
croup, laryngotracheobronchitis,
C.
epiglottitis,
D.
Asthma exacerbation. Answer: C. Epiglottitis. This question tests the recognition of a life-threatening pediatric respiratory emergency. The key clues are fever, drooling, and the tripod position with the chin out, which are the hallmark signs of acute epiglottitis. This is a severe, rapidly progressing bacterial infection that causes swelling of the epiglottis, threatening to close the airway. Manipulating the airway or agitating the child is contraindicated because it can cause a complete obstruction. For example, the child often refuses to speak or swallow because of the severe swelling and pain. In a patient presenting this way, simply administer high-flow oxygen in the position of comfort and transport immediately. Question 20. The most appropriate initial method to open the airway of a patient who is unresponsive and has NO suspected spinal injury is the
A.
jaw thrust maneuver,
B.
Selleck maneuver, cricoid pressure,
C.
head tilt, chin lift maneuver, D. insertion of a nasopharyngeal airway, NPA. Answer: C. Head tilt, chin lift maneuver. This is a fundamental EMT skill question about basic airway management. The core concept is that the tongue is the most common cause of airway obstruction in an unresponsive patient. The head tilt, chin lift maneuver physically displaces the tongue off the posterior pharyngeal wall, opening the airway, and is the quickest and most effective non-traumatic method. The keyword NO suspected spinal injury indicates that this technique is safe to use. If trauma were suspected, the jaw thrust maneuver would be used instead. This simple maneuver should always be the first step in assessing the airway of any non-trauma, unresponsive patient. Question 21. Which statement best describes the legal concept of negligence in emergency medical services?
A.
Transporting a patient against their will.
B.
Deviating from an established protocol without medical direction.
C.
The failure to provide the expected standard of care, resulting in injury. D. Providing care to an emancipated minor without parental consent. Answer:
C.
The failure to provide the expected standard of care, resulting in injury. This question addresses a core legal concept in EMS operations and professional accountability. Negligence legally requires 4 components: a duty to act, a breach of that duty, failure to meet the standard of care. Causation: the breach caused the injury, and actual damages: the patient was harmed. The definition is the failure to perform a required act or performing an act below the standard of care, resulting in harm. For example, failing to splint an obvious deformity on a patient with a stable fracture, which then leads to nerve damage, could be considered negligence. Remember, negligence means you did something wrong or failed to do something right, and the patient was harmed because of it. Question 22. A 30-year-old male has been stabbed in the right upper quadrant of the abdomen. Based on anatomy, you should have a high suspicion for injury to which solid organ?
A.
Spleen,
B.
stomach,
C.
liver,
D.
small intestine. Answer: C. Liver. This question tests basic abdominal anatomy and the ability to predict injuries based on the mechanism of injury, MOI. The key clue is the right upper quadrant, RUQ, which is the anatomical location of the largest internal organ, the liver. Because the liver is a highly vascular, solid organ, a penetrating injury to this area can lead to rapid, massive blood loss and hemorrhagic shock. For example, a stab wound to the RUQ poses a higher risk of immediate life-threatening bleeding than an injury to the hollow stomach or intestine. Always connect the location of the injury to the underlying anatomy to predict the most dangerous potential injury. Question 23. In a patient with suspected opioid overdose, the most important initial assessment finding that dictates the need for naloxone Narcan administration is
A.
pinpoint pupils,
B.
a history of drug use,
C.
respiratory depression or apnea,
D.
unresponsiveness. Answer: C. Respiratory depression or apnea. This question is about the critical indications for administering naloxone in a suspected opioid overdose. While unresponsiveness and pinpoint pupils are common signs, the core problem caused by opioid overdose is severe central nervous system depression, leading to respiratory depression. The primary, life-threatening indication for administering naloxone is inadequate breathing, slow, shallow, or absent respirations, because the goal of the medication is to reverse this respiratory depression. For example, a patient breathing at 6 breaths per minute requires immediate intervention, which can be BVM ventilation first, followed by naloxone. Always remember that the life-saving action of naloxone is reversing the respiratory depression. Question 24. A paramedic is initiating a continuous positive airway pressure, CPAP, device on a patient with severe pulmonary edema. A key contraindication for CPAP application is
A.
blood pressure of 160 over 90 mmHg,
B.
SpO2 of 88% on a non-rebreather mask,
C.
patient unable to follow commands, D. heart rate of 110 beats per minute. Answer: C. Patient unable to follow commands. This paramedic-level airway management question tests the crucial contraindications for using non-invasive positive pressure ventilation, NIPP. The key concept is that CPAP requires a tight seal and patient cooperation to be effective and safe, especially to prevent aspiration of stomach contents. A patient who is unable to follow commands cannot maintain their own airway or effectively manage the mask, making them an aspiration risk. For example, if a patient's mental status is severely altered, an advanced airway intubation would be the more appropriate intervention to protect the airway. Remember that the patient must be conscious and cooperative to safely and effectively use CPAP. Question 25. The correct depth of chest compressions for an adult cardiac arrest patient is
A.
at least 1 inch, 5 cm,
B.
at least 5 inches 4 cm,
C.
at least 2 inches 5 cm, but no more than 2 inches 6 cm,
D.
at least 3 inches 5 cm. Answer: C. At least 2 inches 5 cm, but no more than 2 inches 6 cm. This question assesses knowledge of the fundamental technique of cardiopulmonary resuscitation, CPR, based on current guidelines. Adequate compression depth is crucial because it is required to generate enough pressure to circulate blood to the brain and vital organs. The key is to achieve a depth of at least 2 inches, but to avoid pressing too deeply, which can cause excessive injury. For example, a compression that is too shallow will not be effective, while one that is too deep increases the risk of rib fractures and internal organ injury. Here is a simple tip. Think of the goal as 2 thumbs wide or about 2 inches deep. Question 26. You are assessing an 8-year-old child who is struck by a car. She has a rapid, weak radial pulse, a respiratory rate of 30, and is pale and cool to the touch. In a pediatric patient, the earliest sign of compensated shock is often
A.
a decrease in systolic blood pressure,
B.
altered mental status,
C.
tachycardia and delayed capillary refill, D. bradycardia. Answer: C. tachycardia and delayed capillary refill. This critical pediatric trauma question tests the understanding of how children compensate for blood loss, shock. The key is the word earliest combined with the signs of hypoperfusion, pale, cool, rapid pulse. Children are excellent compensators and maintain their blood pressure much longer than adults, making a drop in systolic blood pressure a very late and pre-arrest sign. Their first response is to increase the heart rate, tachycardia, and shunt blood away from the skin, leading to a delayed capillary refill. For example, a child with an occult bleed might have a normal blood pressure, but a heart rate over 140 beats per minute. Always watch for the fast heart rate and delayed cap refill as the first warnings of shock in a child. Question 27. When conducting a rapid trauma assessment on an unconscious patient who is involved in a motor vehicle crash, the EMT should primarily focus on
A.
obtaining a complete set of baseline vital signs,
B.
finding and treating life-threatening injuries,
C.
taking a complete sample history from bystanders,
D.
Applying a detailed dressing to all minor lacerations. Answer: B. Finding and treating life-threatening injuries. This question is about the purpose of the primary assessment and rapid trauma survey in a critical trauma patient. The key clue is unconscious, which immediately elevates the patient to high priority status because they cannot tell you where they hurt. The focus of the rapid trauma assessment is to quickly examine the patient head to toe to identify any immediately life-threatening injuries, like internal bleeding, chest trauma, or major external hemorrhage, and intervene immediately. Vitals and history are secondary to finding and fixing major bleeds or breathing issues. For example, a rapid check of the chest will reveal an open pneumothorax or flail segment, which requires immediate intervention. The focus is to look for and fix the things that will kill the patient now. Question 28. Which of the following is an example of the medication route sublingual?
A.
Injecting naloxone into the thigh muscle.
B.
Spraying nitroglycerin under the tongue.
C.
Inhaling albuterol via nebulizer.
D.
Giving oral glucose gel between the cheek and gum. Answer: B. Spraying nitroglycerin under the tongue. This pharmacology question assesses knowledge of medication administration routes. The concept is that the sublingual route involves placing medication under the tongue, where it is rapidly absorbed into the bloodstream through the rich vascular tissue vessels. The key word is sublingual, which literally means under the tongue. This route is ideal for medications like nitroglycerin because it bypasses the digestive system for a faster onset of action. The cheek and gum route is called the buccal route, not sublingual. Remember that sublingual, under the tongue, absorption provides a very quick drug onset. Question 29. A 55-year-old male complains of sudden onset, crushing substernal chest pain. He is alert, and his vitals are BP 130/80, HR 92, and SPO 296% on room air. After administering aspirin, your next appropriate step, if authorized, would be to
A.
Administer oral glucose.
B.
Assist with prescribed nitroglycerin.
C.
Initiate a fluid bolus.
D.
Apply a non-rebreather mask at 15 liters per minute. Answer: B. Assist with prescribed nitroglycerin. This question tests the standard of care for a patient presenting with classic acute coronary syndrome, ACS, chest pain. The key clues are the crushing substernal chest pain and the stable vital signs, which allow for the administration of other medications after aspirin. Following aspirin, the next standard intervention is to assist the patient with their prescribed nitroglycerin, provided they have no contraindications like hypotension or recent ED drug use. Applying high-flow oxygen is no longer a standard intervention unless the SpO2 is below 94% or the patient is showing signs of shock. Always remember the common acronym for ACS care: MONA, morphine, oxygen, nitroglycerin, aspirin, but follow modern protocols prioritizing aspirin and nitroglycerin. Question 30. A patient in cardiac arrest has a palpable mass in his neck with tracheal deviation. You should suspect which potentially reversible cause of cardiac arrest: H's and T's.
A.
Hypovolemia.
B.
Tamponade.
C.
Tension pneumothorax.
D.
Hypoxia. Answer: C. Tension pneumothorax. This is a paramedic level question about the reversible causes of cardiac arrest, known as the H's and T's. The key clues are cardiac arrest and the physical findings of palpable mass, often subcutaneous emphysema, and tracheal deviation. These signs, in the context of arrest, strongly suggest a tension pneumothorax, where air pressure collapses the lung and pushes the trachea and mediastinum, heart and great vessels, away from the affected side. This is an obstructive cause of arrest that requires a mechanical intervention, needle decompression, to relieve the pressure and is one of the T causes. For example, the pressure buildup drastically reduces the heart's ability to fill with blood, immediately reducing cardiac output to zero. Always consider tension pneumothorax when a traumatic cardiac arrest patient has obvious chest or neck trauma. Question 31. You are transporting a patient with a known communicable disease. The action that ensures the most effective cleaning of patient care surfaces in the ambulance after transport is
A.
wiping down surfaces with a paper towel.
B.
Using a solution of soap and water.
C.
Using an EPA-approved, hospital-grade disinfectant.
D.
Covering all surfaces with plastic wrap prior to the call. Answer: C. Using an EPA-approved, hospital-grade disinfectant. This question assesses proper EMS operations and cleaning protocols for infection control. The key concept is disinfection, which is the process of eliminating most or all pathogenic microorganisms. After transporting any patient, especially one with a known communicable disease, all surfaces that came into contact with the patient or equipment must be thoroughly cleaned with a product specifically approved for use against pathogens. Using a hospital-grade or EPA-approved disinfectant is the only way to achieve the required level of microbial kill. Simply wiping with soap and water is insufficient to kill viruses and bacteria. Remember that proper disinfection is a standard requirement for safely turning over the unit for the next patient. Question 32. In a trauma patient with no other signs of injury, a sustained heart rate greater than 100 beats/min with weak peripheral pulses and cool/pale skin should make you most suspicious of
A.
psychogenic shock,
B.
early septic shock,
C.
compensated hemorrhagic shock,
D.
distributive shock. Answer: C. Compensated hemorrhagic shock. This question evaluates the ability to recognize the subtle, early signs of shock in a trauma setting. The key clues are trauma patient combined with tachycardia, 100 BPM, weak pulses, and cool/pale skin, which represent the body compensating for internal blood loss, hemorrhage. The body is attempting to maintain blood pressure by increasing the heart rate and shunting blood away from the non-essential skin and extremities. For example, a pelvic fracture can cause a patient to lose 2 liters of blood internally before their blood pressure finally drops. Always treat a trauma patient with a persistent fast heart rate and cool skin for shock, even if their blood pressure is normal. Question 33. A 2-year-old child has a partial airway obstruction from a foreign body and is coughing forcefully. The most appropriate initial action is to
A.
deliver 5 back slaps and 5 chest thrusts.
B.
Immediately begin CPR.
C.
Administer supplemental oxygen and encourage coughing.
D.
Perform abdominal thrusts Heimlich maneuver. Answer: C. Administer supplemental oxygen and encourage coughing. This airway management question tests the specific protocol for a pediatric patient with a partial airway obstruction. The key clues are partial airway obstruction and coughing forcefully, which indicate that the child is still moving adequate air and has a good air exchange. As long as the patient is moving air, the most effective intervention is to encourage them to use their own protective mechanism, a cough, to dislodge the object. Only when the cough becomes ineffective or the patient becomes unresponsive should mechanical thrusts or CPR be initiated. For instance, putting an oxygen mask near the child's face, blow by, provide support without interfering with the cough. Do not interfere with a patient who is coughing forcefully. Let them clear their own airway. Question 34. What are the 3 classic signs of diabetes mellitus, the 3 polys, that a patient may report during the history assessment?
A.
Polyphagia, polyuria, polycystic.
B.
Polyarteritis, polydipsia, polyphagia.
C.
Polydipsia, polyuria, polyphagia.
D.
Polydipsia, polydactyly, polydipsia. Answer: C. Polydipsia, polyuria, polyphagia. This medical emergency question tests the recall of the hallmark symptoms of uncontrolled diabetes, whether type 1 or type 2. These 3 classic signs, often called the 3 polys, represent the body's reaction to high blood sugar, glucose. Polydipsia is excessive thirst, polyuria is excessive urination, and polyphagia is excessive hunger. For example, a patient in diabetic ketoacidosis, DK, will often report these symptoms for several days leading up to their crisis. An easy way to recall this is to associate poly, many/much, with 3 different excessive states: thirst, pee, and hunger. Question 35. As a paramedic, you are preparing to intubate a critically ill patient. Which phase of the intubation procedure involves administering medications to induce unconsciousness and muscle paralysis?
A,
Confirmation phase.
B,
Preoxygenation phase.
C,
Rapid sequence intubation, RSI phase.
D,
Post-intubation phase. Answer: C. Rapid sequence intubation, RSI phase. This is a high-level paramedic airway question focusing on the steps of advanced airway management. The key concept is rapid sequence intubation, RSI, which is the near-simultaneous administration of a potent sedative to induce unconsciousness and a paralytic agent to cause muscle paralysis to facilitate quick and safe placement of an endotracheal tube. The drugs are what define the RSI phase, making it distinct from preoxygenation or confirmation. For example, an RSI sequence might involve giving ketamine for sedation and rocuronium for paralysis. Always remember that RSI is defined by the use of both an induction agent and a paralytic agent for rapid tube placement.